Yeah, Cinemat was the first drug that came out, and it came out in the 70s. And it's made of two things, carbidopa and levodopa. Levodopa is transformed by the brain cells into dopamine. So giving people levodopa actually increases the work the brain cells are doing in transporting it and changing it to dopamine. So the early studies, they took huge, massive quantities, had a lot of side effects, but generally did better. Carbidopa was added in the 70s because dopa gets converted in the gut to dopamine, and having a lot of dopamine in your gut gives you diarrhea. And so when they had the carbidopa added on, Cinemat was born, and it became a much more easy-to-use drug because it didn't have as many side effects. Now, over the years, there have been drugs that have been developed to bypass the whole neuron itself and actually go to the other end of the synapse where the dopamine should be normal. Mirapex is the latest generation that has the beneficial effect of not driving the cell to be more active metabolically. So that's protective to the cell, theoretically. It's never been proven, but that's what the core is thinking.
It was thought at one time that taking a lot of Cinemat could be harmful to the brain, could accelerate the pace of Parkinson's. And there was a tendency among neurologists to try to hold off on giving patients Cinemat for as long as possible as needed. That is really no longer the case. So it's no longer felt that Cinemat accelerate progression of Parkinson. So I think that patients need to know about Cinemat, that they should take as much as they need to improve movement. If they have those significant side effects like dyskinesia, those are very disturbing to the patient, but they're not actually harming the brain. They can always reduce doses of Cinemat if they're having those side effects of dyskinesias, and that won't harm them either. It's just like taking Motrin for pain. It's not correcting the underlying cause of it, it's just suppressing symptoms.
It's very controversial. The use of deep brain stimulation is very controversial at this point. And the reason for that is we don't know what the right thing to do is. And there's actually a conference in Argentina, and the title was "We Don't Know What Brain Stimulation Is." And the problem with it is, it works best in people who are earlier in the course of the disease and who are already being managed somewhat well by medication. And it works a lot better than medications. It allows you to reduce the doses of medication and makes people, the functions that are not helped that much by medication are helped a lot more by deep brain stimulation.
There are some risks of surgery. Take that risk when it is really the right risk. That being said, some patients wait too long for surgery.
But if you have somebody who's relatively young and you put hardware in their brain, there's things that happen like infections, hemorrhages, leaves wandering around. The brain's like a pixel, so it's just kind of wandering around in there. So the cumulative risk to having this in your head over 20, 30 years is unknown, but likely very high. If you wait until somebody's later in the course of the illness, it doesn't work as well. Cognitive side effects tend to be more of the problem.
So when is the right time to have to use?
So that's kind of the problem.
It's when, in spite of optimal medical therapy by a movement disorder specialist, the person has significant disability.
Dancing or running or swimming or walking, all of those kinds of things are really important, not only for improving your social
network
interaction, because depressions are really life-limiting things. Maintaining physical activity is the most important thing for reducing decline in function.